so just try and keep up.
Good afternoon, everybody. My name is Carolyn Dubé. I'm the Executive Director with Fertility Matters Canada, and I'm thrilled today to be here with Dr. Marjorie Dixon from Innova Fertility and Reproductive Health Centre in Toronto, a long-standing member of Fertility Matters Canada and an amazing supporter of fertility care, patient-centered care, access to fertility care, not only in Canada, but across the globe. Dr. Dixon, thank you so much for being with us today.
Well, thank you for having me. It's a pleasure.
So we're going to have a very timely discussion. The COVID-19 vaccine has been rolling out across Canada, and we're getting a lot of questions and concerns, maybe some uncertainty in the fertility community, especially with patients, not only those starting out on their fertility journey and looking at treatment cycles, but also those who have had treatment cycles and are now pregnant. And I'm thrilled for you to be here today to talk a little bit about some of those things. So for the people that are watching either on Zoom or on Facebook, please know that you can ask questions live and we'll have Dr. Dixon answer them within the hour. So I think, Dr. Dixon, I've got some slides here.
Yeah, just to serve as kind of a backbone, a guide-ish.
So I'm going to share those. Did that show up? It didn't show up as a slideshow, did it? I apologize. There we go.
There we go.
Lovely.
Okay, so I think it's important to have this conversation also because there is much in the lay press that is misinformation. And one of the things we pride ourselves on is the public education piece so that we can add clarity through what we really know through the literature. So one of the things is that people need to understand the big difference between the flu and coronavirus or COVID-19. So the infectivity of the flu is, if you have the flu, the regular influenza virus, generally the infectivity is that you might infect 1 to 1.3 people. So one person would infect about one other person. Coronavirus is much more virulent, and it is in the order of 2 to 2.5 people per person that's infected. So if you were to imagine, do you remember the Fabergé Organics commercial from the, they tell two friends and they tell, and so on and so on and so on, and it multiplies that way? It's kind of like that in the exponential rate. And the issue is also the people who are the infectious people. It's not like the flu where people are sick and you see they're sniffly and they're febrile and all the rest of it. There's a long incubation period. So instead of being infectious for 1 to 4 days with the regular flu, you could be completely asymptomatic, not be sniffling, not have a fever, not have any of those baseline signs of the flu that we're screening for regularly now, and be infectious and actually potentially infecting other people for up to 14 days, which explains much of what public health is advising if someone does test positive is that they must quarantine. And then it also explains why we are all locked down in different places within the country, across the country, in the hot spots, because we may have it and be at risk of transmitting it in that exponential way, but not be aware of it, okay? And that's why we are locked down. The other part of it is, when people get the flu, the likelihood of them getting really sick and requiring hospitalization, because sometimes people with the flu do require hospitalization too, but it's a much lower percentage for the total cases. So you'd be looking at only 2% of the people with regular influenza needing an admission to hospital. The issue with the hospitals, and even in my tertiary care center where nurses have been reallocated to deal with the patients that are sick with coronavirus, is because there's a 19% hospitalization rate. And even worse is that there is a case fatality rate of 1 to 3.4%, and versus 0.1% for the regular flu. And so that is why, as a respiratory illness, there's a limitation on what the hospitals can manage, because those that require support with ventilation is high. And if that occurs, then the hospitals have limited resources, right? And even for people who just require support without intubation, there are floors in hospitals that are dedicated to coronavirus patients as opposed to the flu It would have
Of
been a
course.
mutational patient. And so much as people are thinking maybe it's not a real thing, it really is. And it's pandemic proportions. So it is across different geographical regions, across the ocean, all across it's not just epidemic locally, it is pandemic across the world. And so that's why it's so important for us to have some kind of public health way of managing the spread of disease. Okay, so
Wow.
that brings us to the discussion.
This is amazing. Thank you for sort of setting the stage. I think that that's really important to have a look at the science and what this actually is telling us and what we know.
Mhm, mhm, absolute. So the other question that I get, and you can probably move to the next slide, is what impact does COVID-19 or the coronavirus infection, SARS-CoV-2, have on women who are pregnant? Because of course, as fertility specialists, we're helping patients to conceive. And when this all came out, I remember in March, there were recommendations after recommendations, the ASRM in the States and Canadian Fertility and Andrology Society. It was so brand new, and we didn't really know exactly what were going to be the obstetrical outcomes. Now we have a year's worth of information. And so now what we understand is that vertical transmission or transmission from mom to baby is very rare. Okay, so that's an important one because women are very concerned. What if I get it in pregnancy? Doesn't mean my baby's going to get, will my baby die? Those are real questions. Please be reassured, vertical transmission is rare, and that's a global phenomenon that we understand that. Most pregnant women who get infected with coronavirus have mild to moderate symptoms, right? And many are just like everybody else. Remember I said before that it was asymptomatic and that there's asymptomatic spread. Even a pregnant woman can spread coronavirus in an asymptomatic way. So not have any signs of illness. And that's what we worried about initially in pregnancy, because there's, a relative decrease in a woman's immune system through pregnancy, which is why it's so important for people to have their vaccinations ahead. We talk about, measles, mumps, and rubella, because women who are pregnant may be at risk. But now what we understand from the experience through coronavirus and through what the literature is telling us is that the main issue with the women in pregnancy is those women who are at high morbidity risk. So if you're over 35, if you have a history of lung disease or asthma or previous pneumonia requiring admission to hospital, or diabetes or hypertension or heart disease, those women, once they're pregnant, if they get coronavirus, might be at an increased risk of having severe illness. And then there's also the piece of with coronavirus, because we know mostly who are at risk are the elderly, right? And we weren't sure there is a population of younger people who are at risk as well, but we can't identify them. We don't know what the genetic variant yet, because it's still relatively new. So we don't know who will be susceptible, but everybody has knowledge of someone who was a young, healthy person who was affected badly and who potentially passed from coronavirus. So that spreads panic through, right?
Of course.
So that is why if you have other morbidity, you are the person we'll talk about who might be advised to get the vaccination, even as you are conceiving. Okay.
Wonderful.
And then also when you're talking, no, it's okay. I'm just getting, you've seen the stats on the screen, but when we were looking at, we had originally learned from the other SARS viruses that there were some issues with preterm delivery, or we worried about intrauterine growth restriction. Those are not things that we are seeing as pregnancy or obstetrical differences in outcomes. What we are seeing is preterm birth is only 15% in patients who are affected. And then cesarean section, so requiring an operative delivery. Admission to the neonatal intensive care unit, not necessarily for baby or fetal compromise, but also just for observation and support if a baby does have infection or is at risk of infection. And then the 5-minute ACBAR scores are good. Okay.
Great. Okay. Those are really, those numbers are encouraging for women and families who are pregnant. Yeah,
pregnant and honestly, understandably reluctant and frightened because of the lack of entire information, because this is something, it's a developing story. It's a story that we're staying tuned for, right?
For sure.
That's important to have forums like this where we can debunk some of the myths around things. Okay?
Absolutely.
So one of the key things that women who are pregnant or trying to conceive, what you can do to stay healthy, and I have this conversation every day, though electronically, safely with patients, it is keep your healthcare appointments during and after pregnancy. What this has done is it has put people on high alert, and they're like, I've been told to stay home, so I'm not going to go see my doctor. I know I have an appointment, but I'm not going to do that. Please don't do that. If you have a doctor's appointment, that is an essential visit that you should be having as part of your essential prenatal care and management. So wear your mask, wash your hands, keep your distancing, minimize the interactions with live doctors. But if you must and you have an ultrasound or you have a blood test that's issued as part of your care, please do adhere to it. Get the recommended vaccines, as we always do say, for pregnant women who are trying to conceive. So update your MMRs. Anything that your physician has recommended, you should follow through with in the usual way. And then if you have prescription medication and non-prescription medications that you need to access as part of your fertility care or as part of your pregnancy, early pregnancy care, keep not a stockpile, but keep a 30-day supply. Have it such that, and that's actually how they're dispensing many of the medications during this time, because we don't want people stockpiling it, but we do want to dispense it in batches. Such that people will have enough to prevent them from needing to go out too often, but they will have an ability to have the medication that they need in a preemptive way. If you have concerns, it says call your healthcare provider. Well, now we're all tech savvy. And sometimes there are patient portals, and sometimes there are chat places for different clinics and different healthcare providers online. Please use those methodologies to communicate with your healthcare provider. If you do have healthcare concerns, don't minimize things. Do not avoid care. You're still providing care. Women's healthcare is essential. And that's a critical piece of information, because what we're seeing with coronavirus is that people have a reluctancy to access care, even if indicated, by virtue of their fear of disease transmission. So that's a very important one to address. Please do talk, address your issues, and if you must, go into the healthcare provider's office. And then, so don't delay any interventions in care as well. And then finally, take steps to prevent getting COVID-19, okay? This is the most important thing that we can do to prevent the spread of disease, aside from vaccination, which we'll get to. So wear that mask, okay? Keep your distance 6 feet apart. Even with people who you're used to in your bubble, that's one of the things that Public Health Ontario, at least in our province, has been very explicit about. And we know if someone is tested positive, the question that the nurses will ask us and they need to verify is, did you have masks on and were you keeping distance? That decreases the risk of transmission and your risk around having been diagnosed, okay? Wash your hands, wash, wash, wash. I know we're using that hand sanitizer, which is fabulous. I'm probably 70% alcohol from all of the cleansing that I've done. If we tested me, I'd be 70% alcohol. But we also wash. There's nothing like a good scrub with some soap, okay? And then avoid the activities where doing this is difficult, right? So if you think that you're going to a place, so this actually happened to me with my kids tobogganing before we were on lockdown. We thought, it's an outdoor activity, it's a safe thing to do. And we went and there were tons of people and I said, let's go. We had our masks, we were ready to distance. But when you say this is turning into a bit of a crowd, use your better judgment and go back and isolate yourself.
Great, that's wonderful advice, thank you.
Okay. So caring for newborns when the mother has COVID-19, this is an interesting question because we're not sure how it was going to happen because, you know, vertical transmission, I said the vertical transmission from mom to baby is not what we're seeing is happening. So how does a mom that tests positive manage a newborn that is negative, right? So it's not common, number one. Remember I said about vertical transmission, and some newborns have tested positive. Interestingly, those newborns have minimal to mild symptoms for the most part, okay? So
that's great.
Yeah, so that's a good thing. But even in those infants who are negative to a positive mother, the recommendations are the masking, the hand washing, Now, the distancing is difficult, so you need somebody else helping you with the care, but you can pump your milk and then the baby can be fed that milk. So it doesn't transmit through the breast milk to the baby. Okay, so that's an important piece of information, and this is what people are navigating through at the hospitals after birth if mom has tested positive and the infant is negative.
Do we know the incidence rate in Canada of moms who test positive just prior to giving birth? Is that data available yet? It may not be.
I actually don't have it, but I think that it would depend on the jurisdiction as well, right? The prevalence of illness depends on the local manifestation. Even though this is a pandemic, their local epidemic will tend to guide the prevalence of disease in that population.
Mm-hmm.
So it would be very dependent on your geographic location. And actually, I don't have that information right now. Okay, so what you can do is find out for your local jurisdiction what that is. But again, it will depend on the individual susceptibility risk of the mom as well, right? Because we did say that if you have other comorbidities and if you are susceptible somehow genetically, right? Not everybody will be the same and not every population will have the same problems.
Great, thanks.
I love this slide. This is my science geek out slide. And I was talking, my daughter's doing high school biology and she's learning all about this. And I was talking about ribosomes, she got excited. So this is going to bring you back to high school biology. Perfect. And you learn about the cells. So this is speaking to mRNA vaccines, different kind of vaccine. We're used to talking about in pregnancy, about live attenuated vaccines. We talk about MMR, and we worry about the risk of transmission in pregnancy. This is different. mRNA is messenger RNA, and it's a little bit of the blueprint or a little bit of the coding sequence that is for the spike protein. So, you know, we always see all these pictures of that round ball with all the spikes coming out of it for coronavirus. The vaccine is the little bit of the sequence that codes for the protein, for the spike protein that's on the surface. That's how everybody patrols to see what this is that's going through the system, okay? It will actually, that mRNA is very fragile. And so it has to be covered in a lipid coating in order for it to be put in part of the vaccine. And it also has to be kept stable. So not only the lipid envelope has to be kept stable at a really low temperature because otherwise it gets degraded quickly, okay? And that little sequence for that spike protein then uses the machinery in your own cells, called ribosomes, to translate the message to create a protein. And then that protein is expressed and your immune system mounts a reaction to that protein. And so that's called adaptive immunity, okay? And so your body is used by the vaccine to create the protein and the immune response. You need 2 doses of both vaccines. We'll get to the 2 different vaccines. But then when the time comes, if you do get exposed to the coronavirus, the molecule, to the virus, then your antibodies, the B cells, will deploy the antibodies that have been created. Right? So it will allow you to fight the disease as if you had seen it before, but you've never been exposed to virus. Now, the issue with all of this and what all of the talk is that mRNA vaccines are relatively new. They came out relatively quickly and they are synthetic. So they're made in a laboratory. And the reason why we didn't have a whole bunch of mRNA vaccines beforehand is because mRNA is not that stable. So the reason why it needs a lipid coating is so that it will survive the vaccine too, the temperature, and then be able to be used to do the ribosome protein creation and antibody creation. Also, this other part is that when they did the studies, so when they did the clinical trials around the creation of this vaccine, they didn't include women who are pregnant or breastfeeding. Mm-hmm. So much as we believe that it will likely be something that is safe, we do not know that definitively because women that were pregnant and breastfeeding weren't included in the clinical trials. So there is that unknown. We don't know if it might have an impact. But the important thing to say is that it is highly unlikely that there is a problem by virtue of the fact that you are not being injected with a vaccine, with a virus rather. You're being infected with the message to create the protein for your immune system to react to. So it's using the magic of cellular biology to translate a message from a vaccine into your immune system's reaction. Okay, I hope that was clear. I babbled.
That was very clear. Yeah, that's one of the best descriptions I've heard, to be honest. So thank you.
It's really, the coolest thing is the intracellular environment. Even when we talk about fertility and what happens when we're talking about fertility and chromosome segregation in the meiotic spindle, we are marvelously and miraculously made that we can actually be injected with a message that makes our body make a protein to make reactions. Awesome.
It is amazing. Science is blows my mind on the daily basis, and not only in the fertility world, but now with this new vaccine, it's so interesting. There we go. So we've got the.
Yes. Okay. So there are two types of vaccine. We know there's the Pfizer and the Moderna. And so patients will ask, well, is one better than the other? And they work the same way. Okay. Both messenger RNA, both what I said, that little code. Mm-hmm. You still need 2 doses. One is 2 doses, 21 days apart. That's the Pfizer. The Moderna is 2 doses, but 28 days apart. So it takes longer for you to have established that adaptive immunity with the Moderna by 1 week. Okay.
Can I pause right there? I'm curious. I've had people ask, or I've seen in conversation, why we need the second sort of that. Is it a booster that we need, or no, that second dose?
It's not a booster. It's just to allow you to have that much more B cell reaction.
Okay.
Right? So the first is like the production line starts, goes onto the ribosomes. It's making the proteins. You have your first reaction, antibodies created. Get your second dose, you have a boosted reaction again. So you have more of those B cells. So then when you see it, you have proper immunity. And that was to get that 95 or 94% effectiveness. Okay.
Excellent.
The difference is the temperature at which it must be stored. So remember I said that mRNA is very unstable. And so we have to have specific conditions, including that lipid molecule that it has to be surrounded by, because otherwise it gets degraded really quickly. It has to be stored at minus 94 degrees Fahrenheit. That's the Pfizer vaccine. And the Moderna is only minus 4 degrees Fahrenheit. So we have to be very specific in the storage methodologies because we don't want to have the vaccine compromised in any way. And then the FDA approval was for aged 16 and older for the Pfizer vaccine, and for the Moderna vaccine is people 18 and older. Okay, so at the end of the day, they're very similar. And if you are getting vaccinated, we recommend that you take both doses before then pursuing the plan for pregnancy if you have been recommended by your healthcare provider to obtain it. Okay.
Great. That's the next sort of step I'd love to kind of dig into a little bit. You know, for people who are watching who are either in an active treatment cycle or are sort of coming up to starting fertility treatment, how do they know if they should be getting the vaccine if their turn comes? Maybe they are a frontline worker or potentially a teacher. How are you talking to your patients about making that decision?
So I tell the patients, first I explain about the fact that this clinical trials don't include it, which is why there hasn't been a blanket statement for everybody to go, because we just honestly don't have the data. But then I say it depends on your individual risk, because we do provide patient-centered care. And right now, honestly, while we don't know for sure, we have to address it on a case-by-case basis. So it begins, are you a high-risk patient? Are you obese? Are you older than 35? Are there other medical comorbidities? Are you a frontline worker? Are you working in a long-term care facility? Are you working in an ICU? Are you a respirologist that's intubating extubating people? Are you an anesthesiologist? Those are high-risk places. And those actually, you bring me to the next slide and I'll tell you.
There we go.
Oh, actually, that wasn't it. We can go back to this after one more, I think, because I was going to say, yes. So the phases. So the rollout of the vaccine was recommended in a phased way because we wanted to get to the highest risk folks first from a principle perspective or an approach process perspective. Then phase 2 would be for other people who are healthcare providers who are at risk of potentially spreading disease. And then the phase 3 is everybody else. Okay. Phase 1 are the people who are at risk. So when I'm counseling a patient, if she is someone that could fit into that phase 1 rollout, those are the people that I would say, you know what, based on your risk, we'll decide if you should be getting your vaccine, because we don't recommend it. And actually, the SOGC, the Society of Obstetricians and Gynecologists of Canada, in the States, ACOG, have said it's different. There's not enough information for us to either tell everybody to get the vaccine or to tell people not to get the vaccine. Right? So that is why we have to use the clinical acumen and the literature on a case-by-case basis to decide if we recommend it or not. But for those people who have a greater risk of exposure and disease in not getting the vaccination than they do potentially have risks in getting the vaccination, the general consensus is the recommendation should be to proceed with vaccination, even if pregnant. Okay?
Great. And for someone who is in, so going to start treatment, or their treatment cycle would be coming up, or even whether that's a fresh IVF cycle, an FET, an IUI, and it is determined that vaccination would be the best case for now.
Yeah.
Should they put a pause on their fertility treatment? Is there a recommended waiting period once the second dose of the vaccine is received, or do you just continue as scheduled?
So the current recommendation is that you complete both in the schedule. So you either do the 2 28 days apart or the 2 21 days apart, wait 3 to 4 days, and then you can proceed.
Okay.
So so you don't have to wait an additional month or any extended period of time beyond the second dose for the immunity to be confirmed. Okay.
Great.
Yeah. And so interestingly, a little monkey wrench out of Ontario, because this says Ontario vaccine rollout plan. So ironic that I'm talking, because I was supposed to be getting my vaccine on Tuesday and found out on Monday that it was canceled.
Oh.
Yeah, so I, of course, work in a hospital. It's a tertiary care center. I also have fertility centers. So we work there seeing patients. We're doing the masking, all the distancing, all the rest of it. We have special protocols for COVID. We're screening patients, so we're being safe. But in as much as the phase 1 rollout, they were moving into phase 2, and then there was an issue with supply. And that's province-wide. They even opened in the convention center here in Toronto, the first public site to begin phase 3 rollout for everybody. They opened it on Monday. It closes on Friday because they don't have enough doses of the vaccine.
Wow.
So, much as the best laid plans, sometimes
of course
don't end up the way that we anticipate. So, they're asking for patience. And then they also are saying, and this is what we have to be adaptive about, it is, even if we have the vaccine available, we won't have everybody vaccinated. And then there'll be some people who will be reluctant until they have these wonderful sessions like this where you get the information out. But some people won't be vaccinated. So we're going to be having to continue with the measures that public health has put in place, basic techniques of infection control, which are masking, distancing, and washing your hands. And that's going to be a critical piece for a long time for all of us.
Yeah. In terms of just general immunity among the masses, what is the number or percentage of population that needs to be vaccinated in order to consider
that we have herd immunity, the herd immunity thing?
Yeah.
So, interesting that you asked that, because I was asking that question. It was very difficult to find anything about Canada, but I did find out in the US, it's about 3 million doses of vaccine need to get out before we're clear that there is a significant dent being taken in that size population. I don't have that statistic for Canada right now, but we haven't had enough doses across country for us to have made a dent at this stage.
No.
Right? So it's going to be important for us. I mean, there's another company that's coming out with another vaccine. So it's going to be important to see what happens in as much as what percentage of the population, the general population, has been vaccinated, because now we're still working on the pieces that are most at risk, the long-term care facilities and the frontline workers and the emergency departments and the doctors in the ICUs and anesthesiologists. Yeah. So those are the top risk people, and not all of them have been vaccinated. So we're still in the phase 1, even though it started in December, we haven't quite gotten through phase 1. And it's going to be interesting to see if there still is the phenomenon of some vaccine hesitancy. Because
Mhm.
much as there's been a lot of education around this, there will still be that population of individuals who won't feel comfortable. And, people have a right to autonomy. You can't force people to be vaccinated. And the efficacy of the vaccine is only as good as, the public health rollout and the herd, right?
Absolutely.
And that's why they're not letting us travel either, right? Because if we manage to quell the spread of COVID-19 in one jurisdiction and go to a different jurisdiction, we can just start the whole process all over again, right? So
Mhm.
that's why it's going to be so important to follow the guidelines of your local public health and global public health recommendations.
That's great. Now, once someone is vaccinated, they've had their second dose, and they come in contact with the vaccine, potentially come in contact with the virus,
Mm-hmm.
can they then, even though if they are immune because they've got the vaccine, can they still transmit anything to someone in their home or in their circles who hasn't received the vaccine?
They shouldn't, because their immune system should be managing that. So if they're exposed to it, their immune system mounts a reaction, and the B cells send out the antibodies, and it attacks any evidence of virus. So that's the effect of a vaccination on you. I actually don't know what the statistics are for you would need a booster, and you shouldn't need to. Once you have your immunity and you have your IgG, you should not need to have a repeat. I'm sure that we will have more information about this in the long term, but in the short term now, the rollout is to try to get those 2 doses of the vaccine into as many people as possible who are at risk of spreading it.
Great. Thank you for answering that.
Mm-hmm.
Am I going back a slide?
Yeah, we could go back a slide. I forget what the slide was, but it was there purposefully. Oh, it was to talk about the side effects.
Mm-hmm.
So that's a question actually that patients and staff in hospitals and in clinics are asking. What they saw in the study participants is that the biggest was injection site reactions, which is mostly what you get with vaccines. You get the vaccine, you're like ouchie in the local area of your upper arm for a little while. They actually will watch patients for 15 minutes to a half an hour after the vaccine to make sure there's no risk of anaphylaxis, because there is still a small risk of anaphylaxis, and the anaphylaxis is not the low incidence of it. They think is related to the polyethylene glycol. Wow, polyethylene glycol in the lipid molecule portion. So in the conduit to get the vaccine, not to the mRNA itself. Feeling a little tired, feeling chills. In my little anecdotal of all of the doctors that have gotten it, they're like, I don't really feel anything. That they got the injection. Fever, which is one of the things that when you have a child, you bring them for their vaccines, they get a little bit of fever, they say to give them tempura. It is not one of the common side effects reported from the vaccine.
It's interesting.
I don't expect to get a fever, but kind of like fatigue, chills, muscle pains, some joint pains, maybe a little bit of headaches. Those are the common ones. In the lay press, also, there was a reporting of Bell's palsy. So, they're like, oh, you take it, your face will get paralyzed on half your face, so don't take the vaccine. It is not one of the common side effects. In fact, it was only correlation and not statistically significant. So it's not to be worried about.
Wonderful. Sounds very similar to someone who's had a flu shot.
Yeah.
And anybody I know that has taken it, very similar to what you're reporting here, mostly maybe some fatigue and mostly injection site soreness for a day or two.
Yeah, exactly. So kind of the recap of the recommendations is both pregnant and breastfeeding women who were excluded from the trial, so we don't have the data, but we shouldn't be really denying or recommending that there's safety, because we just don't know. And that's why there's reluctance. It's not because we're worried about it. It's just we can't say, and doctors like to be able to say, the evidence says this was the statistical analysis, and this is where you lie in your risk. Right now it's I don't know what it is. That's the honest answer. If you're planning a pregnancy, complete both of the injections as much as possible. If they run out of the vaccine, it's hard to complete, but they're trying to complete those people who had their first vaccine as well. And right now we also don't know if people should delay a pregnancy again because of what I said, right? They weren't included.
Mhm.
And if you're trying to conceive pregnant or breastfeeding, you should discuss your potential risk, because I remember I said there is that population that is at greater risk of morbidity from this. And so we want to be able to tease those people out and decide who should be going and who shouldn't be going for the vaccination, and speak to your healthcare provider, your pregnancy care provider as well.
So if you are pregnant, does that put you at a higher risk for contracting COVID-19?
Nope, good question, but no.
Very good.
And
Very
initially
good.
that was one of the concerns. And we recognize that the answer is no, as long as you are continuing the distancing, the hand washing, the masking. There are frontline workers who are pregnant, who did not contract disease with the proper PPE and
Great.
practices.
That's so encouraging, because the reality is, people are still going to start families. People are still going to be moving through, hopefully, for their fertility treatments. And especially in the world of fertility, as you know, patients are always waiting. They're waiting to get pregnant. They're waiting for, it is month after month after year of just waiting. And when this pandemic hit and the clinics closed back in the spring, I mean, it was incredibly challenging, not only for patients, but for you as fertility experts wanting to provide care. And we know that the clinics closed to ensure that you could reopen and continue care in case, the second wave came. And this country has done a beautiful job of, maintaining reproductive health care to patients.
When it first happened, there was a lot of discussion. It was great because from across Canada, all of the fertility care providers came together, and we had forums and we had discussions and we came out with guidelines. But the main thing was we felt a tremendous responsibility to the general public health and safety. And much as we wanted to get our patients to care, like we clamored, we tried, we wanted to make sure that if we were bringing patients to care, we were doing so safely, right? And so segue to now wave number 2. And at least now we have the playbook and we know what it is that we need to do to ensure that when we are delivering care, we're doing so in a safe way. And then also, having been, I feel like I did a lot of online and Instagram throughout the pandemic, and people would feed in and we would answer questions. It is terribly off-putting to be in the trying to conceive community on a regular day. Add the pandemic.
Yes.
And changing the way we communicate. So we aren't supposed to be communicating face to face. We are online, we are, in EMRs. It is a different way of providing care. And, we don't get the see, feel, touch. We don't get the hey, get touchy, it's gone. Hard for the community.
Absolutely.
And so I found that adding information and advice and just much more transparency about everything that it is that we do or why we're doing it or how we're providing service has helped. But it has been a real 2020, whatever.
Yes. And, when you're going through fertility treatment and your care team, your fertility care team is such an integral part, and it's an intimate experience, and you rely on the touch, the feel, the connection as you're trying to build or create a family. And we hear a lot in the community from patients, that's been removed for obvious, and of course everybody is understanding as to why that's happened or why it is happening, and we're very optimistic that someday it will return to that. But it is a challenge, not only for patients, but also for you and the care teams in your clinics who want to be there to hold a hand, to show their smile or their caring eyes in ways that are more challenging right now, even just in terms of telemedicine. You've opened up the door, I think, for so many more opportunities and more access to care in terms of rethinking how appointments go and using telemedicine to connect with patients in more remote areas, which is incredibly amazing. But it has removed that human piece of such a intimate experience.
Yeah, we adapt and evolve. And we try, you know, to take lemons and make lemonade, right? I remind patients that we were closed and we couldn't provide care at all. And, you know, much as patients are now cycling, I did 5 retrievals this morning. So we are providing care spaced apart with the masking. We can't do the hugging, but we still do the baby dusting. And we have to find ways. So what we do now at Inova is that if a patient does come in and their partner can't be there, just like in the hospitals, actually, we allow for patients to FaceTime, right? So we bring in the technology so they can get excited and be in the room. And, you know, our ORs are kind of spa-like. We have spa music. I let people pick their music. Like we find ways of bringing the human aspect into care to provide humanized fertility care in different ways in spite of the technology. And technology can be used also in ways that we might not have considered until something like this happens, right? So
Agreed.
change can be good. There's a lot of off-putting. There are a lot of off-putting things about coronavirus, but there are some silver linings that we have evolved in some ways to the better for patients.
I would agree with you, and I'm hearing that in some of our support groups. You know, the ways that they feel more supported almost, and the way that teams are coming together to help them through the journey. It's amazing. One thing, and this is not really vaccine related per se, but one of the ways that the coronavirus has really, or one of the groups that has been really affected are those patients who will be using third-party reproduction or surrogates living in other provinces than the intended parents, potentially living in separate countries.
Yes.
How has that affected, you know, building families this way? And how are you and how are other clinics kind of helping to make that happen?
That's a great question, actually, because when this first happened, it did create a delay, a substantive delay, because we weren't allowed to travel and international or even interprovincially. Now we can't travel interprovincially. So there is a little bit of a pause. However, I can say that before we were back on lockdown, we have a very busy third-party program at Inova, and we were getting a lot of babies because we were bringing a lot of our patients to care, because what we did was we doubled down and we organized systems and process, added people to the team that were dedicated just to that, and got better processes to bring people to care. So much as initially getting the gestational surrogates from out of province, then it lifted slightly. The summer was a bit of a honeymoon, right? And then it got cold again. But we were able to create the embryos. And so we have those cryopreserved and tested and ready to deploy as soon as we have the gestational surrogates. And now there's a pause again, but we've had many gestational surrogates get to care in the months of, like, for the fall and then into December, even for the Christmas holiday. So we are still thankfully recognizing that we have to organize differently. But it is difficult. You just have to think outside of the box. We're still able to do things, but we have to manage ourselves differently and ensure that we're managing to bring our patients to care through other methodologies, through collaboration. Like,
Yes.
we're thinking outside of our box in a way that maybe we might not have been moved to do. There was no real impetus to change that substantively in such a short period of time. But the reorg is necessary because we are big on access to care for our patients. We're in this to bring patients here. This is my passion, is to get everybody care who so deserves it, regardless of whatever barriers they may be encountering. And we know that geography can be a boundary, particularly for our intended parents in the third-party program. So we are working around those things, but you're right, they did put a monkey wrench and they did put a bit of a dent in the plans. I guess it would also depend on what jurisdiction you're in and where your gestational circuits are coming from, right? So we're fortunate to be in this big center where there are a lot of people available, maybe more than in other jurisdictions, right?
Yeah, it's amazing. I want to commend all of the medical team and the reproductive experts from across Canada for really coming together in the past few months, especially initially, to just figure out how to continue care safely, to continue help people, you know, start families, to get pregnant, to continue treatment, because, you know, everybody's working and busy. And when that happened, it was a really beautiful thing to see. And I think that that's something that we should celebrate as patients. So from the patient, yes, from the community, thank you to all of the fertility clinics and experts and the CFAS for coming together to figure this out for us. It was incredible.
Yeah. It's lovely to collaborate with our colleagues. You know, we don't always have opportunities beyond sometimes our annual meetings. And so it's nice to have, well, not an excuse. This is not the excuse we're looking for, to collaborate and work together. But it was an opportunity to commune and share our expertise for the better of our patients collectively. Right?
Absolutely. I completely agree. So before we wrap up, I don't see any active questions that have come in. Is there anything else you'd like to touch on before we tie things up?
I think because the vaccine, it's a developing story, right? Kind of like the US inauguration. Stay tuned, because we want to be certain that when we do make recommendations, we have the amount of evidence that's required for us to do so in a certain way. So in a way with certitude, right? So we will have more information as things progress, but do watch, because it is a developing story.
I agree. Thank you. Thank you so much, Marjorie, for being here today. We really appreciate the information. I think that so many people who are watching live, and if they're going to watch the replay, will get great value in the information that you shared with us today. And if you're looking for more information or would like to connect with Dr. Dixon, you can connect with her through ANOVA, Fertility and Reproductive Health in Toronto, at ANOVA. I can't remember your handle on Instagram.
Info at ANOVAfertility.com. I might get in trouble for that. Oh,
okay.
goodness.
And if you're on, it's info at ANOVAfertility.com.
I did it.
You did it. And they're also incredibly active on social media. So Instagram or Facebook, connect with them there. They're very responsive. Marjorie, thank you. I know we've got some projects coming up together, so I'm really excited to collaborate. Thank you for your continued support of all Canadian fertility patients. Thank you for tuning in. This is another episode of Figuring Out Fertility. We are Fertility Matters Canada, a registered Canadian charity. And if you have the ability to donate to our charity, you can do so by finding more information on fertilitymatters.ca. Thank you so much.
Okay, it's a pleasure. Nice seeing everyone.
Bye, Marjorie.
Bye.